Welcome to the Home Health Minute, your monthly podcast brought to you by the Home Health section of the American Physical Therapy Association. Hosted by Troy Mead. Hey everybody, and welcome to part 2 with Cindy Krafft around Oasis D. If you're listening to this when it's released, then you still have time to see your presentation at CSM 2019 on Oasis D. I'll be there as well at CSM, so I hope to see you there and say hi. So now let's go to part 2 with Cindy Krafft. I think you made a pretty important point, or at least something that stood out when you were talking about how it's seen as the Oasis is as a discipline document. Would it be an accurate assessment to say that overall, generally, a lot of nurses and therapists as well feel like it's a nursing document, and then and that therapy doesn't fit in well to that?
You know, having done Oasis training for a long time now, I really try to stress that at times we're our own worst enemy when it comes to this tool. We, because of our clinical training, we're going to bring a clinical eye to it. We are. You can't turn your physical therapiness off. You have it 24/7, 7 days a week. You can't go on vacation. You can sit on the beach with a drink in your hand and somebody walks by and you're already doing gait assessment whether you want to or not. So everything you do, you're going to bring a clinical perspective to it. But at times with Oasis, we project that onto it as though what it's asking me is a very specific, and if it looks nursing, well, it must be theirs. This instrument from day one has been, we are just collecting bits of information. And if you think about a lot of these questions, Troy, especially in the functional areas, all they do is allow you to capture that a problem exists. It does not go into the why they need assistance while they do something, why they're a fall risk, why they have a pressure ulcer risk. These are a lot of very, very superficial level questions. I don't mean invaluable, but just very high level snapshots. The why is still what the clinician has to be doing in the rest of their documentation. We put on the detective hat and figure out why this person is having this problem. And two people can get the exact same Oasis score for vastly different reasons, depending on what's going on with them as an individual. For people who say, well, I really hate that thing, could you imagine if they tried to make it clinical and put every possible reason why a person couldn't bathe by themselves or why they couldn't walk by themselves? I'd argue even if these questions had 100 responses apiece, which would horrify most, you'd meet Mr. 101 the next week that didn't fit into the ones you had. So I look at it as, let's leave the clinical to the clinician. That's our job. That's what we're trained to do. These are snapshots of information. And that my responsibility is to use the best response possible. And some of the statement, and many of you have ever heard me before, have probably heard this, but I think it bears repeating. I went to a training early on in my Oasis experience, and it had the opportunity to have one of the original developers there. And her comment to me to this day is just burned into my head, in that sometimes the correct answer is 2.5. And if you think about that for a minute, it's very liberating to me, because it says we have created a tool that's just looking at pieces of information with a limited number of responses. So we're acknowledging that sometimes your patient doesn't cleanly fit into one of those. That doesn't mean the Oasis is stupid or that this is ridiculous or a waste of my time. The 2.5 means I pick the best from what I have and I move on. So it doesn't need to be this, I'm always angry, I'm always frustrated, there's a whole list of things I hate about this. And I'm not saying I love it or that people should love it, but we need to make peace with it, because the only people we're driving crazy at this point is ourselves. Because CMS believes every answer that's reported. They don't have a choice. They're going with you're the professional, you filled it in, you've read the rules, you've had your training. So if you tell me this person is independent with this activity, then don't tell me you ordered therapy who's working on that activity, because now this doesn't make sense. Or the patient you put down, you only think this issue is temporary, and now you're on your 4th cert period. Okay, how is a temporary thing taking 4 cert periods to deal with? How can a patient, looking at our current Oasis today, have such trouble dressing and bathing and walking, but they're completely so much better, basically independent at grooming and making sandwiches? Those inconsistencies confuse CMS because they believe our answers. So we have to figure out a way to make sure we have the appropriate information, choose the best responses from what we have, and then own that I will take this the route I need to go as a physical therapist to figure out the real reason behind why this problem exists and what we're going to do to address it. But I can't use that to say, this item is dumb, I don't like it, or I've not even read it anymore. So, there's been a lot of discussion, Troy, about the functional questions, and therapists score them, quote, better than the nurses, and that proves their therapy questions. I audit a lot of Oasis, and I'm not convinced that PTs are inherently better, any better than nursing and answer those questions, because I don't think we're reading and owning that piece of information and using the guidance as indicated.
You seem very passionate about Oasis D.
Well, I think it's something that it clearly isn't going away. We're going on 20 years, and now we're seeing, things are being added, the GG and the J, to increase harmonization. So now for the first time, we're looking at a body of questions that are exactly the same questions and the same guidance and the same response options for skilled nursing facilities and for inpatient rehab. So now this opens a world that isn't just comparing my agency to another agency in my community or my state to another state. We're talking about the ability to compare how a patient does in a home health situation versus a nursing home versus inpatient rehab. And I don't say versus like we're on some sort of, adversarial front, but being able to measure the impact of care across the continuum, we have not had items like that before. And one of the other things I do is I participate in some of the follow-up analysis of the data for the comprehensive joint replacement program. And sitting in on those calls, it's so frustrating because they're trying to compare the impact of care in IRFs, SNFs, and us, and they're using 3 different instruments, the IRF-PI, the MDS, and the Oasis, and then trying to draw connections between how well patients do and having to repeatedly point out the defects of the inconsistencies between those tools. So Oasis D, bringing in those items, really is giving us an eye toward this is going to be able to be part of the value discussion, not just of our setting individually, but where it fits into that larger post-acute continuum. And the early data in that program clearly indicates a reduction in SNF use and a reduction in IRF use and an increase in home health use. But again, the quality of that is measured by Oasis. So that tool doesn't go anywhere, and we're clearly seeing that after all this time, the visit counting thing is finally ending, which we've been threatening and talking about for years, but now we have a date on it. Oasis isn't ending anytime soon. So I think we need to take our therapy expertise where it is and absolutely advocate for it as a profession, but we have to learn to speak the language of the industry when we talk about value. We aren't going to preserve our role on that team by continuing to talk about we help people walk better, and my goal is to get them to the mailbox. People listening to this, Troy, I doubt they're the people that write things like that anymore. People that come to CSM are not the ones that do that. But I spend a lot of time reading therapy documentation going, we're dead. We're dead. You can't just talk about improved independence or increased dependence. I'm like, I don't even know what increased dependence is. You're either independent or you're not. I don't understand. So we have to really look at that beyond just the therapy feeling pieces and I don't think it devalues what we do, but it helps it connect better into the larger conversation. And all roads end with, what are we doing that keeps people out of the hospital? I mean, that continues to be the big discussion in relation to our value as part of the continuum. And when I sit in meetings and on calls and it's, the nurses do this and the nurses do that, well, does therapy do anything to reduce hospitalization? I can't tell in our documentation because we're on long walks to nowhere and we transfer better and we bathe better and we communicate better. But I see nothing that says, and I'm also going to tell you why this keeps this person out of the hospital. It's expanding the discussion, recognizing that if we just sit in our lane, 2020 could do some serious changes to our access to patients in this industry. And at the end of the day, it will be the patient who's worse off. And that's not something we should allow to happen.
Now you mentioned CSM. You have an you have an upcoming presentation at CSM. Is that correct?
Yes, I do, and I was kind of pleased that it's actually in the middle part of CSM. When I've done Oasis in the past, I've ended up in the last slot on the last day, and some very brave souls have stuck it out. I remember it was in New Orleans. I'm like, really? The last slot on Saturday. So we're basically into Saturday evening in New Orleans. Who's going to want to talk about Oasis? But people do show up. I think people really are wanting to make sure we do this right. So this time the session is actually Friday morning, which, I hope it's not too early for folks. But I named it Life After D-Day. Definitely pun intended with it being Oasis D, but I think for some it's like, oh gosh, here we go again with these kinds of things. I don't think the changes are insurmountable. I do think it balances out against 28 items coming out, but I think we're naturally inclined to focus on what's different, what's new, what's more work. Oh my gosh. That's why I say, well, 28 coming out is part of the balance of this. And that GG section, I don't think, let me rephrase that. I think it could have been better worded, potentially, but its appearance on the stage in 2019, 1 year ahead of PDGM, is perfect timing for us to show our value in that collaborative data collection model, to accept the invitation and to show what we do is more than just pumping out visits. Because if our agencies don't submit correct Oasis data, the damage to the industry will be long-term. It will continue to be, I'm not giving you more because your patients are not that complicated. They don't have these needs because your responses indicate everything is great. And if everything is fine, why are you seeing them? Why are you providing services? So the long-term ramifications of incorrect Oasis data we've seen over and over and over again in other areas. I think we can jump on this here, especially in an environment where nursing is quite anxious in many organizations about the GG, that we could, kind of ride in on our horse and be that partner and solidify our spot well beyond any discussion about payment methodology. So that's really what I want to bring to that session as well. It's not going to be, let's all sit in a room and read the manual. We can read the manual, but how do we talk about those interaction between items, what we need to be looking for, and some tools around how do we really develop that team presence that doesn't facilitate the I know more than you do, you just, you're just a nurse. We don't want to go there. But how do we really do this effectively and efficiently without turning everything into, the worry about this is going to, make my life miserable and every visit 10 times longer? How do we really get to what we need to as efficiently as possible?
Yeah. Yes, it sounds really valuable to all home health clinicians, whether they're new or been in for a while.
I would also, by extension, Troy, I understand that, PTAs don't complete the Oasis, and that hasn't changed with Oasis D. But if you're talking about, many of the items referencing the assessing clinician's ability to get information from others who have had direct access with this patient, that would mean the information from a PTA would also be up for discussion in relation to how does that factor in to the ultimate decision of the admitting clinician to pick an answer. But if I'm a PTA who says, well, I don't fill it out, so I don't need to know anything about this, I'll just sit over here and do my thing, I also think it's a missed opportunity. You don't need to know every nuance of everything because you're not going to collect it, but being able to incorporate that language in interacting with nursing and where it fits in our documentation could be huge. And I think that many organizations shy away from, educating those who don't fill one in. But I think all this collaboration, especially at a venue like CSM, I know there's a lot of competing things to go see, but I wouldn't want PTAs to just assume that's not for me because I don't do admits, because it's going to be a much larger conversation, especially with that final rule coming out.
That's a good point. Yeah, I don't think many think about that point, but yeah, when it comes to collaboration, they're just they're valuable assets as well. Is there anything else that you would like to add about Oasis D that we haven't already talked about?
I just think whenever possible, when it comes to Oasis, that again, it's not a Pollyanna approach to it, but I'm seeing as we enter, get closer to January 1, this negativity that it's all awful, it's all terrible, I hate it. And it's like, can we at least try to not go negative? I'm not necessarily saying, you're going to jump up and down and be excited, but can we at least try to keep the conversation within our agencies on it is what it is. Make sure we have access to the guidance, that we're reading the guidance, we read the question. Yes, those first few months always have some bumps as we make that kind of adjustment, but we have collaboration, we have directions, we're not being thrown to the wolves to answer this. It's not, I got to have a super secret club membership or I'm never going to know what I'm doing, and we can be successful. I think part of the reason agencies struggle is everything is terrible, everything is awful. Isn't it terrible that Medicare makes you do this? I mean, I've had patients say that, Troy. Isn't it awful that Medicare makes, well, who's telling the patient this? Why would they even know, let alone think it's awful? Somebody's now venting to the patient. How do we put it in its proper context? It is a reporting mechanism. It's a standardized reporting mechanism. I need to learn the language, learn the guidance, pick an answer. Sometimes it's 2.5, and oh well, I would have preferred a better response than that. But these are my choices. I pick it and I move on. And I integrate that idea into my care planning. And so it's not Oasis is one thing and my care plan is something completely different. It needs to be integrated where we make peace with it. If that's one thing I could make happen, Troy, it would be, kind of to refocus the dialogue away from it's an onerous requirement and isn't this miserable and it's out of scope and all these things that just add to it, and say, all right, with Oasis D, let's just treat it as a clean slate. What's in here? What do I need to collect? What is that language of value? And this is part of being a good therapist in home care. You can't keep saying, I'm a wonderful therapist. I don't do Oasis, or it's dumb. I always end up with corrections, or, oh, it's a nursing thing, because none of that is what this tool was intended to be. And I think when we change the conversation, it reduces our own level of GERD that tends to come along with anytime somebody says Oasis. Much like the holiday ads can cause the eye twitch, you will always know who's worked in home care in the last 20 years, because when you say Oasis, they do not think of beaches and palm trees and cocktails. Oasis tends to produce the same eye twitch. And I would love to see us at least neutralize the conversation going forward. Even just for our own sanity, it would be great.
Yeah, that's true. Well, thank you, Cindy. That was a lot of information, and I think your passion really shows. And anyone that's listening, I would encourage you to get on the Oasis train, and now, while it's leaving with Oasis D, and if you're at CSM, then come out and join your talk. Well, thank you very much, Cindy. I appreciate it.
Thanks for having me today.
Thank you for listening to the Home Health Minute, the podcast from the Home Health section of the American Physical Therapy Association. Check out our website at www.homehealthsection.org. There you can find links to this episode, tons of helpful resources for your practice, and how to connect with us on social media. Thanks for joining us, and we'll see you next time.